Well, very welcome to everyone in Asia and elsewhere who's joining us for this. We've enabled the transcript, so if my English is too fast or too unclear, hopefully you'll be able to read it. It was suggested we talk about gastric polyps, and I have several good examples to share with you. And we will start with the most common one, or one of the more common ones, the hyperplastic polyp. These, I've just put in here a nice histologic description from Pathology Outlines, which I use quite extensively, and I hope that you also find it useful. Noting that these hyperplastic lesions are predominantly foveolar epithelium, the surface epithelial type, and that there can be erosion, ulceration, as well as other types of metaplasia like intestinal metaplasia or even pancreatic metaplasia. And of course, the important thing is we want to make sure that we don't have dysplasia, which can be of several types. This is one of the more worrisome findings for potential premalignant polyps. So here's an example, and this looks very edematous and some dilated glands here with, as you'll see, a predominance of foveolar type epithelium. And as you can also see here, we start to get a little bit of blue mucin and the formation of possibly intestinal metaplasia in this lesion. In fact, I think I highlighted an area where we're getting a beginning of a blue type mucin here that would indicate we have intestinal metaplasia. These can be variably edematous as well as have dilated glands, so they can look a lot like juvenile polyps. So this could be mistaken for a juvenile polyp as well. However, we don't, in the absence of a syndrome, you could just call it safely a benign hyperplastic polyp. I've got several examples of each of these polyp types. Here's another one. Again, we see areas of edema, some dilated glands, and a predominance of foveolar type epithelium cells. But here, no, we're beginning to lose the mucin to the foveolar cells. So there may be a little bit of dysplasia developing, as you see some of the architectural changes. And I believe, looking over this, well, here we see a more classic area of definitely hyperplasia with nice foveolar epithelium here. Note that you can get some inflammation. Some of the times that will involve the lumen. That's all okay. We'll go on to another slide here. Another example of this hyperplastic polyp. Here we see a little bit more predominance of the epithelial component, but again, still some complexity, variable architecture, branching, hyperplastic epithelial cells, basal nuclei, and here you can see a few giant cells, histiocytes, here in the mix as well. As inflammation, these can become eroded or ulcerated and get granulation tissue forming. So those are all considerations that you might see in this. Now, these can also be multiple. As you see here, this was several fragments. And so it can sometimes be a little bit tedious to look for dysplasia, but you do want to make sure that you have excluded that possibility, because it certainly raises the importance of follow-up in these patients if they have dysplasia. And here's an area right here where I think you can say that we've lost the mucin, the architecture has changed. We've got more mitoses, we've got some atypical features here. So I think calling an area like this dysplasia would be highly appropriate, and certainly raise the concern for more frequent or earlier follow-up in these patients. And you can see several areas along here where we have dysplasia. So Dr. Tuan, so yes, serrated adenoma, we don't define serrated adenoma in the stomach. So I think in this situation, we don't need to worry about that consideration. We don't need to differentiate from that in this setting. But that's a good question, because certainly some of the epithelium can appear that way. Here's another example where we'll have some dysplasia, and I'll just highlight again the normal over here. And then, as we saw, this more bluish area over here where we have lost cytoplasmic mucin. The nuclei are more up and down. There's more pleomorphism to the nuclei. And you'll see, as you see here, some nice increase in mitoses, and even some atypical mitoses right here in this case. All right, so hyperplastic polyps, foveolar epithelium, dilated glands, complexity, and the potential for dysplasia to develop, and thus the potential for malignancy to develop in this situation as well. Here's another example. Same story, a little bit more villous appearing in this situation with these elongated villus-like structures. And you can see there is some degree of sort of maybe antral type glands that are persistent in this. And this will bring up one of the differential considerations that we will consider, which is when would you call this Menetrier's disease or something like that? And that's a good question, because we'll see in just a minute when I bring up one of those cases that they can look very similar to this. And the main difference is that you get a history that it's a diffuse change rather than a localized change. So here's a small area again of dysplasia. Note the nuclear changes between these dysplastic glands here and the still hyperplastic ones over here. Coarse chromatin, nucleoli, and again, a change in the cytoplasm, a little more nuclear pleomorphism, some mitoses, highlight areas of dysplasia. And sometimes you may have difficulty distinguishing an area like that from maybe microinvasive carcinoma. That might also come into the consideration. Another example, this one again, very busy and more kind of low-grade dysplasia. You can see here lots of areas of nucleoli, mitotic activity, and a little bit of beginning loss of the cytoplasm. Now, there's something else going on here, however, and that is as we look at the stroma here, you see that we have a signet ring cell carcinoma here that is developing in the stroma. So sometimes you'll see these in situ neoplastic signet cells in the epithelium, in the epithelial compartment, and other times you won't. I think if I looked hard enough, I could find some in this particular slide. I think maybe there's one there, a few up here, and so forth. But underscores the importance of looking at what's in the slide and identifying the potential for, or what's in the stroma, identifying the potential for invasive neoplasia. As you can see here, there's several areas in this lamina propria where we have these abnormal cells in the stroma. Here we don't see them, in other areas we did. So this was a very sobering case. This patient actually did have multiple hyperplastic or adenomatous polyps, or hyperplastic polyps, adenomas, and several of them had these foci of invasive carcinoma. I don't recall if this patient had a CDH1 deficiency or not, but that could also be a predisposition. So here is an example of Menetrier's disease, and this was a resection specimen. But as you can see here, this polypoid area has, foveolar type epithelial cells, some edema, very pronounced hyperplasia of these superficial foveolar cells, and some of them can begin to look polypoid. As you see here, these sort of look a little bit on the polypoid side of things, as you see here. So this enters into the differential, and primarily it's the endoscopic appearance of a diffuse change versus a localized polyp that would give you the distinction between the two. All right, so an overlapping feature that, as we've indicated, can be juvenile polyps. But what we see here is that we have the cysts and we have normal gastric epithelium. So there'll be some measure of either antral or body type mucosa along with the polypoid change. There will be the foveolar hyperplasia and possibly ulceration, inflammation, and so forth, but you should also be able to identify some measure of normal antral or body type epithelium. So here's a polyp, and as you can see, we have this cystic edematous pattern. And if it's just nipped off the surface, you may not see that pattern of epithelium of the normal gastric epithelium. And I'm trying to think here, I think we got down to a little bit of more antral type epithelium here, but it was very difficult to see because most of this polyp is just foveolar epithelium with dilated cystic changes. This patient did have juvenile polyposis syndrome, and so the fact that it looks very similar to a hyperplastic polyp should not be overlooked because the differential for the two will be there. And so I didn't have a really great example of a juvenile polyp with normal gastric epithelium. But let me see if there was one here on this other page. Nope, I don't see it on their list here. So we'll go back here, and you'll just have to take my word for it that this patient had juvenile polyposis. So the next disorder is, again, a very common disorder, the fundic gland polyp. And this is triggered by cystically dilated glands, which have chief cells, parietal cells, and occasionally can have the mucinous foveolar cells. But seeing the body type of epithelial cells lining the dilated gland is pretty much the sine qua non of making this diagnosis. Now, there may be hyperplastic parietal cells and some snouting and so forth seen in patients who have proton pump inhibitors. So that can mimic the fundic gland polyp or be present in combination with it as well. Dysplasia is decidedly rare in these type of polyps. So I've got several examples that will illustrate some of the spectrum here. And at low magnification, you can see that there's not very much in the way of dilated glands. So here's one. And then the rest of these are sort of dilated foveolar glands. But let's look first at this one here and satisfy ourselves that the lining epithelium here is a mixture. Here's a couple of foveolar cells, and then we have some parietal and chief cells here. This is a little bit cauterized, so not well preserved. We'll have better examples later. Here's another example here, mostly foveolar cells here. So let's go on to a better example that's not so cauterized. So here's a florid example, lots of dilated glandular spaces. And here you can see we have a mixture of the mucinous cells, as well as you can see these oxyntic cells, the eosinophilic cytoplasm, a few chief cells with more bluish cytoplasm. So this qualifies nicely as a fundic gland polyp. And is clearly that extreme state where virtually every gland is dilated. So that's kind of the easy one. The harder ones are those that just have a few dilated glands, and this is a nice example here of what we see with that. So here are a couple of dilated glands down here, and you can see nice parietal and chief cells around this dilated gland. Here's a few mucinous cells here. Again, another dilated gland over here, and a little bit of stuff in the stroma. But beyond that, not much else. So just very subtle glandular dilatation. And this also would qualify as a fundic gland polyp. So those are two very different extremes, but that's important to recognize some of the divergent extremes that we can see. Here you can see almost how this is truly a polyp. Sometimes they're just very, very small nubbins on the surface. But again, here, variable dilated glands, mucinous glands, mucinous epithelium, as well as the other epithelium we've mentioned. So I'll post the link to these slides for you to look at afterwards when I have the recording up. Peutz-Jeghers polyps, again, are part of a syndrome that can be seen with oral pigmentation, gonadoblastoma in the ovary, or sex cord stromal tumor with annular tubules. But in the GI tract, more frequently, we see these arborizing branches of smooth muscle from the muscularis mucosa. And these have generally a normal but somewhat hyperplastic or disorganized mucosa. So we can see this in the small bowel, in the colon, as well as in the stomach. I suppose theoretically we could see it in the esophagus, and I don't know that I've ever seen one that I felt was a good example. Sometimes there's what we refer to as pseudo-invasion, where you have sort of displaced epithelium with associated hemosiderin and mucinous cysts. So here's an example. I believe this is from the small bowel, because I had difficulty finding a good gastric example. But here you can see these sort of multinodular areas, and here we've got the villus structures and this intervening arborizing branching strands of smooth muscle. So you may have to go to higher magnification to convince yourself that this is indeed smooth muscle here and not fibrous tissue. But you'll also see here that we're dealing with intestinal type epithelium. But in the stomach, you could again have these branching patterns of smooth muscle as well as normal mucosa. Now, I think I did have an example here on this one that I wanted to, yes, here it is. So hopefully this will load quickly. And so here's one, well, not loading particularly well. And it's not depixelating, but I think you can see the smooth muscle and the other features here to some degree. It was gastric type mucosa. Let's see if we can pull it up here. So I think you can maybe take my word for it that this is sort of foveolar type of epithelium with some antral type of glands. So we'll go back to our other slides, which will be more in focus. Okay, so another polypoid lesion that we can encounter in the stomach is the inflammatory fibroid polyp. And this also can have edematous and sometimes dilated glands, but primarily this is a submucosal lesion that has sort of a spindle cell stroma with vessels and sort of maybe some onion skin pattern of spindle cells, a lot of eosinophils associated with this. And this can sometimes extend up into the lamina propria and thereby be obliterative or obliterating the muscularis mucosa. So there I've got a couple of examples of this for us to look at. So here's one from our laboratory. And as you can see here, the distinction here is that you do have essentially a normal pattern epithelial surface, or at least a thickness of the epithelium that's fairly normal. So I'll just come down here and you'll see that this is a defined mucinous epithelium, maybe with a little bit of intestinal type of metaplasia. So we've got some goblet cells here, but not the villus formation that you'd expect if we were in the duodenum. So this is in the stomach and may indicate that there had been some prior Helicobacter, or maybe it was atrophic gastritis or something that had caused the intestinal metaplasia. But it's not thickened. Now notice, however, that in this case, we don't have a muscularis mucosa. It's totally gone. And these spindle-shaped cells are, in fact, extending up into and in between the gastric glands, and there's a bit of a sort of a granulation tissue pattern on the surface. Here we see more of this ulcerated appearance and granulation tissue. Now, whether this is the initiating event and then this reactive stroma or this spindle-shaped stroma is the secondary event, we don't really know, but it certainly could be because we know that there are spindle cell proliferations that follow mucosal injury in other organs. And here you can see the mixture of vessels, the spindle-shaped cells, the stromal cells, bits of hemorrhage, and so forth. Now, if you're in doubt as to whether this is muscle or stromal proliferation or something of that sort, you can certainly do other stains to document that this is not smooth muscle. But a very simple stain to do is a trichrome stain, which I have an example here. The trichrome stain is very useful because it does help to differentiate spindle cell populations that are producing collagen as opposed to spindle cell populations that are producing smooth muscle. So here's our lesion, and we see it's all blue. And we also see that we don't have any band of red here. So we don't have any evidence of a muscularis mucosa. And just to be certain that we're staining appropriately, here's our control tissue, maybe an appendix here. And you can see here that the smooth muscle of the appendix is staining with the appropriate reddish color, whereas the stroma here and the epithelial components and the lymphocytes and so forth are not staining with that configuration. So the control was functioning properly, and we can demonstrate that we have lost entirely the muscularis mucosa, and we have a fibrous collagen-producing spindle cell population that is proliferating here. So I think I have another example. Oh, no, I don't have another example. Okay, well, I think actually there were an example or two in the Michigan slides here. I wonder if I can find it here. No. Well, for contrast, we'll look at this slide here. It's going to load. Well, it's not loading very well, so we'll just skip that. I have the leiomyoma of the muscularis mucosa can also occur in the stomach and can produce a polypoid structure, and it will have the pink smooth muscle type appearance that you see with leiomyomas elsewhere. So pyloric gland adenoma. So these can occur in the stomach, usually in the antral area, but also in the duodenum. And these are composed of what we'd expect, the pyloric glands or pseudopyloric glands, the tubular glands with very clear cytoplasm, maybe a little bit eosinophilic, and basally located nuclei. These can be associated with dysplasia, both high and low grade, and even with adenocarcinoma. So they are significant to identify and be aware of that possibility for dysplasia. I don't have examples of all three of those, but I did find this a nice example here of a pyloric gland adenoma in our collection. So here we can see what looks a little bit like hyperplastic foveolar glands, but we have also some more tubular type pyloric glands associated with that in a more condensed format. So lacking the dominant cystic changes, but finding lots of these small tubular glands like you see here, it should not be termed a hyperplastic polyp or an adenoma, but a pyloric gland adenoma, because these are more reminiscent of the true pyloric glands. And notice here, sometimes even these cystically dilated glands will have smaller areas that are more typical of the pyloric type of production. So an interesting sort of differential here to find these small, closely spaced glands here. Now, in terms of dysplasia, you can, of course, look with both scanning power for areas that look distinct or different to identify the possible presence of dysplasia in one of these lesions. So I think this is certainly in the differential diagnosis of hyperplastic polyps or adenomas, but if you find enough of these small tubular glands associated with the foveolar epithelium, I think the pyloric gland adenoma is the better term. So this one polyp has multiple areas, variable cellularity, and really the best and most diagnostic areas were some of these and those up here. Not all of the fragments had equivalent areas of diagnostic certainty. I'm not sure what they were dotting over here, but okay, so let's see. Here's another example, also a pyloric gland adenoma, a polyp, this one more clear cut, little foveolar surface epithelium, focal intestinal metaplasia, and here are these foveolar type glands, excuse me, pyloric type glands. Now this one also has a cute little finding here, a set of glands that look somewhat different. And as you'll notice, these cells have very granular cytoplasm. They have some of zymogen granules here in them. This is a small focus of pyloric metaplasia, excuse me, of pancreatic metaplasia, pancreatic acinar type epithelium. And that also will enter into the differential for these adenomas, whether they're in the duodenum or in the stomach, is pancreatic heterotopia or metaplasia. And here's another example. A little different staining. Foveolar type epithelium here. And then we find areas here where we have nice tubular glands associated with this that would correspond to the pyloric glandular tissues. So not overwhelming here, but probably the better course to call this a pyloric gland adenoma, which are usually not as pedunculated and polypoid as the hyperplastic or foveolar type adenomas. Well, something that can enter into the differential at times and look like a polyp in some circumstances is the Xanthelasma. Now, I don't know if in Asian cultures you find this very much because the lipid storage disorders are probably more frequent in Europeans, but these are sometimes associated with lipid metabolism disorders. And these patients may have cutaneous xanthelasmas as well as enteric ones. But essentially, these are just foamy histiocytes in the lamina propria. And they look like a polyp endoscopically. They'll often have a yellowish discoloration. And you can see here that we have foveolar epithelium. We have some antral type prepyloric glands. And then we have what's going on in the lamina propria here. And as we come into higher magnification, we see that the cells here have this sort of pale, slightly foamy cytoplasm that we associate with histiocytes. Now, if you're uncertain as to whether these are histiocytes or stromal cells or something of that sort, you certainly could do a CD68 or CD163 stain to verify that these predominant cells here are histiocytes. You might also be wondering, well, could these be a manifestation of Whipple's disease? Could this patient have a infection with Topherema whipplei? Boy, I remembered the name of that bacterium. How about that? Not bad for someone who's my age. And if that's the case, then certainly doing a PAS stain could be helpful as well. Now, you may notice we have an artifact here, this sort of eosinophilic angulated material. This is not an organism or such thing. This is what's called gel foam. It's a sectionable material that can be used to flatten or to hold on to the tissues so they aren't lost. And was used quite a bit previously, not so much today. All right. Well, I mentioned pancreatic ectopia or heterotopia and metaplasia. And this is when we find pancreatic acinar epithelium that may or may not have ductal epithelium associated with it. Interestingly, this occurs both in the setting of Barrett's esophagus, sometimes in atrophic gastritis, and sometimes without. This is not, however, in and of itself associated with increased malignancy, although I have seen cases where sometimes the gastric carcinoma looks very similar to an acinar carcinoma of the pancreas and may have trypsin positivity. So it's certainly not impossible that a heterotopic or metaplastic pancreatic tissue can develop malignancy. It's just not common enough to make it reportable, or at least common knowledge in the literature. So here is a representative biopsy, and we'll take a look at this. As you can see, we've got some chronic gastritis that probably is due to Helicobacter in this case. And let's see if we can see the organisms here, because it certainly looks like they ought to be here. Well, I don't see them on the scan. But anytime I see this density of lymphoid infiltrate, I would look for those organisms and certainly do a stain if I did not find them. Then, as we look up here, we see something that looks a little bit different. And as we come in here, we see we've got some ductal type tissues and a little bit of sort of almost acinar type of epithelium. Not really good for diagnostic acini, but certainly consistent with a little heterotopic pancreas. Because as we can see here, here we are getting the mixture of these granular zymogen secreting cells. So in this case, this is actually heterotopic pancreas because we have both the acinar tissues as well as some ductal tissues associated with this. If we just have the acinar tissues, then I think metaplasia is probably the preferred term, less likely to be ectopic or heterotopic pancreas. Now, this can be a little bit difficult to distinguish from chief cells in some circumstances because of the granular nature of these cells, but I think in this case it meets the test. Here's another example. And here we see a few ductal structures and nice granular acinar type parenchyma here. And this is associated with also some stroma and a little bit deeper in the tissue here in the antrum. So as you see, sometimes it can be a little bit on the subtle side, probably won't present as a polyp at this size, but it might be something that the endoscopist sees and suspects is something a little bit abnormal. If you can believe it, I have another example here, and I would say at low magnification, it's probably going to be this little structure here. Sure enough, there it is, ectopic pancreas. We would not think of metaplasia in a submucosal location like this. This would be ectopic or heterotopic pancreatic tissue. And as you can see here, we're in the gastric antrum. More gel foam, as you see here. So you're going to get a 2-for-1 out of that slide. Now, I found this mention of oxyntic gland adenomas on path outlines. And of course, we'd expect to find these in the body and fundus where you have the oxyntic type mucosa. And these would be somewhat irregular glands that have associated smooth muscle. Now, how would we distinguish this from from fundic gland polyp? Because these can also be branched and so forth. Well, it's actually this smooth muscle is the feature that we would like to see. They will occasionally have parietal cells and mucous cells, again furthering the potential confusion with fundic gland polyp. But this would be a more defined proliferation of the glands rather than a sort of a nodular, a clonal expansion of the glands with this associated radiating smooth muscle tissue. So I can't find an example slide-wise in our library, but I did want to include it here for completeness. Now, maybe what we can do is take a look at some of these other slides and put these up as quiz cases. They're not going to load. Well, shame on you, Michigan. You're not helping me here. That's not going to work. Okay, so here's a polyp. Let's see if we can get into reasonable magnification here. Let's describe what we can see. We've got foveolar epithelium. We've got some smaller glands. We've got a little bit of, looks like muscular stroma there. A little bit of branching. What kind of polyp would you want to classify this as? We're in the stomach. If you don't want to speak up, you can just type your comment in. Is it a hyperplastic polyp? Is it a juvenile polyp? Is it a fundic gland polyp? Is it a Peutz Jeghers polyp? Is anyone listening? Okay, someone's typed in their example. Hyperplastic polyp is a suggestion. So I think that would be a good diagnosis. I think, however, because of this smooth muscle that is here, I would actually favor this being a Peutz Jeghers polyp. You just see a few of these wisps of smooth muscle here, and I think that takes it out of the hyperplastic polyp category. The stroma in a hyperplastic polyp is usually just very edematous with no smooth muscle. Okay, so that was a learning point there. Let's look at this one. So here we have some dilated glands, the foveolar epithelium. Edematous stroma. I don't see any smooth muscle.
Pyloric gland adenoma.
So this is an adenoma, I agree. The question is it a juvenile polyp or is it a hyperplastic polyp? So hyperplastic polyp. I think hyperplastic polyp's a good choice. It does seem, however, to have some stroma here. So I would hold the possibility that it could be a juvenile polyp if the patient had a known syndrome. But I think otherwise I would call it, as you did, a hyperplastic polyp. Okay, very good. Let's see if we've got another one here. Oh, no, that's not going to come up. Well, that's the one we tried to get before. And that's not going to show up well enough to work with. Okay, here's another one. So here is a rounded polyp. And we have a little bit of surface hyperplasia. We have some preserved glands. We have then some stuff here in the stroma. I'm sorry this is not focusing very well, but I think this may actually help you to focus on here. So we have some stellate cells in between the smooth muscle, which is kind of splayed apart. Here, let's see if we can see it over here as well. Here you can see a little bit of that change here in the stroma. So this is an example of an inflammatory fibroid polyp, where it's the stroma, the spindle-shaped cells in the stroma that is the proliferation rather than the epithelial component. So I'm sorry that didn't load well enough to give us a good image of this polyp, but it was intended to be an inflammatory fibroid polyp. Okay, well, coming back to our cases here, any questions you want to bring up or anything, any of these slides you'd like to look at again? Just to review, as I said, I'll post the link here in the chat so that if you want to go directly and look at the slides yourselves, you can do that. But I'll also include that in the meeting. So that's what we've got prepared for today. It's not quite an hour, but a quick run through on some of the common polypoid lesions and some of the less common lesions. And some of the differential considerations. So does anyone have any other questions?
I have one question.
Yes, Dr. Mary.
Yeah. In gastric biopsy, you will classify like the high grade or low grade in all the specimen if it is adenoma or not.
Good question. Yeah, when we have dysplasia, do we classify it as a high grade or low grade? I typically do not. I noticed that in some of the descriptions for pyloric gland adenoma, that they specify that in that situation, they may do grading of the dysplasia. But I would consider any of the adenomas, the hyperplastic polyp, et cetera, or the Fundic gland polyp that develops dysplasia, a premalignant polyp that has dysplasia. If it gets to the point where it's what we would call high-grade dysplasia, that's also kind of adenocarcinoma in situ, which in the stomach is essentially gastric carcinoma that's T1A. And so we don't differentiate high-grade dysplasia usually in the stomach. Dr. Duan has asked a question. How can we differentiate? Oh, Dr. Mary, did you have a follow-up question?
No, after the answer.
Okay. So Dr. Tuan asks, what are the key points to differentiate hyperplastic polyp with dysplasia and pyloric gland adenoma? So let's just go take a look at the hyperplastic polyp with dysplasia again, and pull this slide up here. So hyperplastic polyp with dysplasia, you'll recall, has clear-cut changes cytologically. So we have areas where we lose the epithelial mucin content. So here's some areas here where we still have mucin. Here we have dysplasia and we're losing that mucin. And we're also getting high-grade nuclear features. So nucleoli, coarse chromatin, pleomorphism. Now in our pyloric gland case, we don't have that same loss of cytoplasm. So here we have a little bit of nuclear hyperchromasia in these glands, but it's mostly, I think, just that they're very crowded and cut thickly. In general, these nuclei the glands are smaller and rounder and so forth. I don't know, does that answer your question, Dr. Tuan?
Thank you so much for your answer. I understand.
Okay. Professor Vatana, do you have any comments?
Yes, of course. Do you hear me?
Yes.
Okay. My question is, in daily practice, the clinician, the endoscopy, sometimes they can find even some tiny polypoid in the stomach, just around 2 or 3 millimeters. Then they biopsy. I think it's good like a hyperplastic polyp, but it does not fill all criteria. It just shows only foveolar gland larger and numerous, but the stroma looks normal. So I could not conclude this is really hyperplastic polyp. I usually say just I found foveolar gland hyperplasia. Is it correct to report this?
Yes, I think that's the best approach. And I often will take the same thing with a very small lesion where I don't have all of the features. I'll be descriptive. We have foveolar hyperplasia. This could be the beginnings of a hyperplastic polyp, but I don't have all of the diagnostic criteria. Similarly, in the colon, sometimes we see mucinous gland hyperplasia before we have the development of tubular adenoma with dysplasia. And so I'm also descriptive in that situation, recognizing that that may be the beginnings of a polyp.
Maybe the beginning. Okay.
Yeah.
Okay. Yes.
Yeah.
So maybe we can put this word. Yeah.
Yeah. Good question.
Yes.
Any
Another
other question?
Yes. Yes. Can we see other condition in case we see the Oxyntic gland dilated hypertrophy? We usually report this is PPI in use, but can we have another condition that show this morphology?
Well,
I mean, not always from PPI.
Yeah, so with proton pump inhibitors, it's usually you see a slight dilatation of the glands, the oxyntic glands, with a little added space there. And that's usually a more diffuse change. It's not like a pyloric, or excuse me, not like a Fundic gland polyp where it's a few of them or scattered here and there. But I am not seeing very many situations that I can think of where you truly have pyloric tissue hyperplasia, or excuse me, oxyntic glandular hyperplasia. I think there's sometimes an age-related difference. Some patients will have a very robust oxyntic glands, and then as they get older, they may lose some of that substance. But I'm not aware of a non-adenomatous hyperplasia of the oxyntic type glands. I'd love to see it. If you have
Thank
an
you.
example sometime, please share it.
Okay. You know why I asked you this question? Because I got usually with poor clinical information from the clinician. I don't know whether patient have been used PPI inhibitor or not.
Yeah, no, we
So
are the
worry
same.
about the report this.
Yeah,
Yeah.
yeah, we are the
Thank you.
same, and we sometimes say it, and they don't comment, and they don't call us back and say no, that's bad, but it doesn't make a great difference as long as you don't confuse it with a Fundic gland polyp, because that has a more serious consequence. Yeah.
Yes, yes. Okay.
Well, very
thank
good,
you.
everyone. It's been good to be with you this evening. I will look forward to meeting again soon, and I'll post the recording soon as well. Thanks so much for your questions and a very good discussion tonight.
Thank you, Professor.
Have a good day.
Thank you so
Thanks so
much.
much for your lecture. Goodbye, Professor.
Good day, good day.
Good day.
Goodbye.